It is just a huge honor for me today to be podcast interviewing Dr. Bobbi Stanley, DDS, MAGD, DICOI, LVIF. She's a graduate of the University of North Carolina at Chapel Hill School of Dentistry, but education has been a mainstay of her 25-year career. As owner and principal dentist of one of the largest comprehensive dental practices in North Carolina, her goal has been excellence in patient care through continuing education, the latest dental equipment and technology, and superior materials. Dr. Bobbi Stanley reinforces these guiding principles with her team members and offers a myriad of opportunities for dental continuing education for associate dentists, auxiliary clinical team members, and dental office team members. She is a master in the Academy of General Dentistry, Diplomate in the International Congress of Oral Implantology, a fellow with the International Association of Orthodontics, and a fellow at the Las Vegas Institute for Advanced Dental Studies. She is an adjunct professor in the Department of Prosthodontics at her alma mater, the University of North Carolina at Chapel Hill School of Dentistry. She is co-founder and senior instructor at Stanley Institute for Comprehensive Dentistry in Cary, North Carolina, as well as a senior instructor with the International Association of Orthodontics in Milwaukee, Wisconsin, the Facial Beauty Institute in Memphis, Tennessee. She is married to Dr. Robert Stanley, and together they have 4 children. She is an instrument-rated pilot and has completed an Ironman triathlon. I think the only thing you could do next is just be the president of the United States.
No, thank you.
No. I mean, your resume, it almost sounds like science fiction. How did you accomplish all of that while having 4 children? You must have not slept in the last 25 years.
Well, life is great, and I believe in living to the fullest. So I'm going to accomplish all my dreams. I have a long bucket list, and I just go through them slowly and check it all off.
Well, this is Dentistry Uncensored, so I don't like to talk about anything that everybody agrees on, but there's a lot of girls listening to you right now that just graduated from dental school, and they're saying, come on, Bobbi, you graduated in the golden years of dentistry, and I'm coming out of school, $350,000 in student loans, and she's wondering if that was even a good idea. What would you say to her questioning going $250,000 in debt to become a doctor of dental surgery?
Well, I'm going to tell you, we mentor a lot of young people in dentistry, and I encourage especially young females to go into dentistry because it's such a wonderful, wonderful profession. We have the opportunity to give back. We have the opportunity to change lives. And in doing so, we can still be a mom. We can still raise our children. We can still have a life. It's the best of both worlds for me. I love it.
So you still think it's the golden era of dentistry?
Always. I sure do. I think there's lots of opportunity out there. Everybody has teeth. Everybody needs help. It's great. Even with big corporate dentistry, which is what everybody's afraid of, corporate dentistry coming in and taking over dentistry, there's opportunity. We're here to give back. We're here to serve. We're here to take care of our patients. And I truly believe, I always have believed, that you do the right thing, you take care of your patients, and everything else takes care of itself. It's always going to be the golden age of dentistry. Dentistry is a great profession.
And what I love most about you is a lot of people who are doing what you're doing, they're in Beverly Hills, they're in downtown Manhattan, they're in Key Biscayne. No offense, but you're in the middle of North Carolina. I mean, you're close to Raleigh. I mean, you're not exactly in Beverly Hills 90210, but you're still doing Beverly Hills 90210 dentistry.
People still want it, and it's amazing. People literally will fly here. I have patients in London who fly to me for cosmetic dentistry. It's just everybody wants it, and when they find somebody who has a talent and somebody who has a heart for it, you don't have to worry about patients. They will do the right thing because they want to have a beautiful smile. They want to be healthy. So it's available anywhere.
The only people that fly to see me as their dentist are family members out of state wanting free dentistry, and I have to buy the plane ticket. So kudos to you. Well, one of the things that you're at such a different level, and when they come out of school, they just do one-tooth dentistry. I mean, someone comes in, it's usually, if you look at the insurance data, the 4-6-year molars are the ones most likely to get any form of treatment, and they're doing one-tooth dentistry. But you're doing comprehensive dentistry. And I don't even know when they get out of school if they're even ready for comprehensive dentistry. I mean, you kind of got to, if you're going to play football, you need to learn a tackle, a block, a pass, a reception. When you come out of school, you need to learn how to do a filling. along their journey, are they even ready to go from one tooth dentistry to quadrant dentistry to full mouth dentistry? When would the Stanley Institute even come up for someone who just got out of dental kindergarten school?
So I'll tell you right away, when they get out of school, their first thought is, I got to get my speed up and I got to make money to pay down my debt. And what I would encourage them to do is to broaden their horizons. They really need to think about investing in themselves and learning. And what I find is that when young people get out of school, they don't want to invest any more money in themselves because they are in debt. And I get that. But if you don't continue to learn and grow and invest in yourself, you're not going to grow. When I got out of dental school, first thing I did was sign up for the Pinky curriculum. I just thought, I've got to learn. I got the basis in dental school. Now it's time to take that to the next level. So I would not tell them to hesitate to start learning even more, because you've got very minimal in dental school. And you're right, Howard, you need to learn how to do a basic crown and a basic filling, get your speed up for that. But the only way you're going to be able to do dentistry and take care of your patients is if you understand the broad scope of things. So I wouldn't encourage you to jump in too fast, but pick one subject and really hone down in it and get really good at that, and then pick another. And whatever your passion is, that's where I would start. I find a lot of young people want to start with where the money is, and the money's going to be anywhere where your passion is. So just figure out what you love about dentistry and just get really, really, really great at servicing your patients with that. And that's a great place to start.
You know, I've always had two types of dentists. There's the blood and guts dentist who wants extractions, place implants, root canals. And then there's the ones that they really want to be electrical engineers. They want to do bleaching, bonding, veneers, Invisalign. I could call you the queen of blood and guts dentistry. I mean, you like the implants, the surgery. What would you say to someone who's, she's young, she just got out of school, and she's saying, I don't know if I like blood and guts. I think I just want to do pretty soft stuff, bleaching, bonding, veneers. How did you get into blood and guts?
Sure. So one reason I went into general dentistry was because I wanted to do it all. I love it all. I want every part of it. And so what I did was I became really, really educated at every aspect of it, because here's the thing, whether I'm going to do it or not, I need to know it. I need to understand it, and I need to learn it so I can communicate with my patients. So at Stanley Institute, we teach dental implants, and we often have students who come and take our course, and they don't want to place implants in their office, but they want to understand implants enough that they can educate their patients and send them to the appropriate surgeon who's going to place the implants for them. And I believe that every dentist needs to be highly educated, even in the surgical part, whether they're going to be the surgeon or not. Because you, as the general dentist, needs to drive the treatment. You need to drive the treatment with your specialists and take care of your patients. So you have to educate yourself from every aspect, whether you plan to do it or not. It's not okay to say, I'm not going to do the surgical part, so I don't need to learn about that, because you do need to learn about that.
Yeah. So talk about your journey. I mean, how did the Stanley Institute evolve? Where did that come from?
So I became a dentist way back in the early days, way back in the early days. And when I met my husband said, gosh, my grandfather was a dentist. I always thought I would be a dentist, but I went down the route of engineering. And he went on, got his PhD in engineering, and he kept saying, I really want to be a dentist. And so one day he came home from work and said, I really want to go to dental school. So we talked about it, and we consulted about it with a lot of people, because we did have our small children, and we decided that was the best thing for him to do, was to quit his wonderful, awesome, high-paying job and go back to dental school. And so we made the sacrifice for him to do that. And then he joined me at Stanley Dentistry. And when he came in to join me at Stanley Dentistry, our dental office became this really great comprehensive office, because we had two doctors, and we really loved providing service to the highest quality. And our colleagues actually would often ask us questions. How do you do this? What do I do in this situation? And we would advise them a lot. And finally, somebody said, why don't you guys teach? So we started a study club. And we started a study club where we were the primary teachers, and we would present on different cases. And we started doing it so much, and we loved it so much, we decided, let's put a curriculum together. And so the curriculum was developed out of need and out of want from our colleagues. They would say, can you guys teach a course about this? And we would say, oh, yes, we can. And so what has happened is, because implants has become the focus with Stanley Institute, we put together a curriculum, because patients wanted not only to learn about placing implants, They wanted to be able to place implants here in the United States, and then they wanted to be able to restore those implants. So we have a whole curriculum that teaches how to place implants, why to place implants, where to place implants. And then we give the doctors the opportunity to place the implants on live patients. And then they also have the opportunity to restore those implants. So it's a start to finish, because one of my big things that I'm always saying is anybody can put a nail in a wall. But when you hang that picture on that nail in the wall, that's going to tell the true story of whether that nail's in the right place. And that's how we feel about dental implants. We want the implant in the correct place, not just in bone, but in the correct place to put a tooth on that implant, because your patient wants a tooth. They don't just want an implant. So you have to be able to start with the process in mind and back up to the surgical. And that's what we teach at Stanley Institute.
Well, I want to back up even further there, because she's coming out of school, and you know, when they graduate school, they haven't placed one implant, they haven't done one Invisalign case, they haven't done one sleep dentist. I mean, I talk to people. I went to a bar the other day, and she came out of school. She had one molar root canal. One. That was
wow.
it. I mean, I did 15 canals, and then so basically, my question is, before you start telling me what we're doing in Cary, North Carolina, she's coming out of school saying, well, should I learn more on implants, Invisalign, sedation dentistry, sleep apnea, TMJ? She can't take everything at once. So when you come, so give her that stair step. I mean, why should she learn implants instead of Invisalign? Let's start there, because you're an orthodontic guru too.
Sure. Yeah. Before she even starts to think about that, I would think about where her passion is, what she enjoys doing, and then start focusing from there. So if she enjoys crown and bridge, great. Then let's start focusing on cosmetics and veneers and making beautiful smiles. If she enjoys orthodontics, then I would start with Invisalign, because it's a small stepping stone to get you to full orthodontics. If she enjoys surgery, by all means, let's start with some simple extractions and some simple implants. But it's got to be, you have to start with your passion. And what I would encourage students and young doctors to do is find a mentor. Find somebody you can ask questions, somebody that's been through the CE who can guide you to get great CE, and somebody who's always there for you if you have a question about any of your procedures that you're doing along the way. But Howard, it starts with your passion. You have to start with what you enjoy the most, and then you go from there. So
the Stanley, so you basically have E1, E2, E3, E4. So it's plan, E1's plan, 2's prepare, 3's place, 4 is prost. By the way, on the placing, if someone's licensed in Arizona, can they place an implant in North Carolina, or is that a legal issue?
Yeah. No, North Carolina Dental Board allows doctors to come in under my license, because I'm an AGD accredited educator. So they will allow them to come in under my license for education purposes only. So they can practice dentistry in the state only during the class.
Huh, that's amazing. Some states make it just... Most states make it to where you have to go to the Dominican Republic to learn how to place an implant. I'm down here in Arizona. If you cross the border of Yuma, there's all kinds of implant institutes. And what's sad is they're placing them on poor people in those countries, when Phoenix has got enough poor people to do it all day long. Regulators...
Absolutely.
Regulation is... I've never been a big fan of regulation. Talk us through... It's a big commitment to say... I'm in Salina, Kansas. I'm going to drive 2 hours to Kansas City, fly to Raleigh, go to this course. So that's a big. So break it down. Talk about what is E1, E2, E3, and E4. Try to bridge the gap between I'm just hearing about it versus I'm buying a plane ticket.
Sure. So E1 is basically getting ready to prepare for implants. So there's a lot that goes into implant dentistry, like the materials, the design of the implant. And you need to understand all that so you can choose the right implant for your patient, because let's face it, all implants are not made the same. So it's important that you understand that, you understand the placement, what kind of patient you're looking for, the treatment planning, speaking with the patient. So that's what the prepare part is for. At the same time, we also will educate your team members. So team members will come to that, and they will have breakout sessions with the financial administrator, with the hygiene, or with the implant coordinator, so that your team can get trained also, because it really is a team effort with anything that you do in dentistry. And what we find is when doctors get educated, if the team members are not on board, then the doctors go back and not a lot happens. So that's what happens in E1. It's a full comprehensive for doctors and team members to be on board to understand dental implants. E2 is planning.
Wait, I want to interrupt the first one. I get this valid complaint all the time that they feel like before they can go take a course, they have to pick an implant because a lot of the implant instruction is driven by the company. So you have a Diplomate in the International Congress Oral Implantology. You're a heavyweight in this. What implant, you said all implants are the same. So what system are you recommending?
So all implant systems are not the same. We use exclusively BioHorizons in our office. So we teach BioHorizons, but we teach it from a direction that you can use any implant system, because what we teach really is guided, but we use the BioHorizons system. The reason we use BioHorizons exclusively is that we love their material and we love their design. And as I said earlier, my husband has a PhD in engineering, so he has broken down the systems in detail, and he teaches in E1 why an implant is a superior implant, what you look for. He never says you need to use BioHorizons. He just says, make sure you look for these things. And there are other systems out there that are great systems. We just happen to exclusively use BioHorizons, and so that's what works for us.
It's an amazing place. A lot of people have never been to Alabama, but Birmingham, I mean, that's where they're making the Space Shuttle Columbia solid rocket boosters and fuels. It really is like a Silicon Valley in the middle of Alabama. It's an amazing company. I've been trying to get Steve Bogan to come onto this show. He's the president and CEO of BioHorizons, but he's too shy and humble to come on Dentistry Uncensored. So smack him upside the head the next time you see him. Tell him to put his big boy pants on and come on the show, because I'm a big fan of theirs. And the reason things you got to remember, in my 32 years of being a dentist, and you know how many implants were placed 20, 30 years ago, and the company's no longer even existing?
Right.
And you know how many malpractice cases people go before the jury, and they ask for research about this implant you're using, and there's no research to support it? I mean, it's the major leagues. I think we're probably down to only about a half dozen major league implant companies, but at the IDF meeting in Cologne last month, over 400 companies were selling implants, and
amazing.
350 of them don't have much sound. Okay, I got to ask you another question though to start. So she's thinking about getting into implants, and but she's thinking, well, I need to buy $100,000 CBCT. Does she need to buy a CBCT before she gets to the Stanley Institute?
She does not, but she does need to have access to a CBCT or be able to send her patient somewhere, because one of the things we do teach is standard of care, and we believe that CBCT is becoming the standard of care for dental implants. So there are a lot of x-ray or radiology centers that can get her an x-ray. There are a lot of doctors now who have the technology in their office that will allow patients to go and get that x-ray. We actually have doctors who send their patients over to our office for a CBCT, and we just send that back over the internet back to the doctor, and the doctor takes care of it. So you don't have to invest in that at all. There are centers and other offices that can do that for you, but it is important to have a CBCT to be able to plan appropriately.
And what CBCT did you get? And the reason I'm asking is I get a lot of feedback at howard@dentaltown.com, and most people complain about my hairdo or whatever, but they want specifics. They don't like generalizations. She's sitting there thinking, come on, you've been doing this 25 years. I'm at school. That's why I asked you what implant you placed, and then she's going to know what CBCT did you pick.
I don't mind sharing at all. We picked ICAT, and the reason we picked ICAT is because they have very clear resolution, and we like that a lot. and it has a lot of diagnostic ability. So it works really well for us.
Why do you think it is that whenever you meet someone who's really placing a lot of implants, periodontists, orals, or whatever, it seems like they got the specialty market. It seems like there's not really a debate among specialists of what CBC. They always seem to get the ICAT. Why do you think that is?
Well, I'll tell you, for the last 7 to 10 years, we had a different system in our office, and it was a little bit harder to diagnose from that. And it didn't seem to be developing or being on the cutting edge. There wasn't a lot of software upgrades to it. And, we got the ICAT, and it's just really changed the way we've been able to diagnose, not just for implants, but for airway, for ortho, for many other things, endo. It's just a clearer resolution. And the whole purpose of this is diagnostic ability. ICAT's always there for you. I mean, they have their reps are available. They're there to help you in any way possible. So they seem to be the cutting edge, staying on top of what we need as dentists.
And they're right up the, they're not actually, they're in Pennsylvania. That's fairly close to you, right?
It is, but I have no idea where they are. Is that where they are?
Yeah, they're in Hartfield, Pennsylvania.
Okay.
I was lucky when we were little. And by the way, you and I each have 4 kids. I had 5 sisters and a brother, and our vacations were only 2 things: either one to go to Six Flags or something like that, Disneyland or whatever, or go to a factory and see something made. And it's so funny because my 4 boys, they've taken a tour of probably 50 dental manufacturing things, and it's so informative. It's like, man, if you really want to know an entire product from head to toe, just go there. And so we were talking about your continuums, and E1 was planning, and we talked about the implant biohorizons, the CBCT, and then I interrupted you rudely as you were getting ready to talk about E2.
So E2 is where you really start to get in hands-on, but the doctors feel like that they have a hard time planning. They don't understand the planning process, and they seem to think it's this big, mysterious thing to plan from the pros perspective for an implant. So we really hone down on that in E2. We help the doctors plan. We give them a little bit of hands-on how to plan. We talk about bone grafting, when you need it, when you don't, what you use, that sort of thing. And then from there, we plan all the patients that are going to be surgically placed at E3. So each patient gets planned for their implant. So we go through about 15, 20 patients and start planning implants on those patients.
Another confusing thing when you're coming out of dental kindergartner is it's tricky because they go back, and a lot of them get a job with their parents. I mean, I'd say a quarter of the class of any dental school I've been in has a family member, a mom and dad, an uncle, someone in dentistry. Yeah. And it's tough because they're going in there and dad's been doing it this way for 30 years and mom's been doing it this way 30 years. And she talks about that she wants to start grafting after an extraction. And her mom or dad just looks at her like a deer in the headlight. What do you think about, let's say I came into your office and I had to have a first molar extracted. Would you graft that? And yes or no, or why?
So I'll tell you, we're really big on immediates. Anytime we can place an immediate, we will, even in the molar position. And my husband has actually developed a technique called the 5-thread rule, where he can actually look and tell the probability of an implant being successfully placed in a molar position based on the number of threads that we can get in bone. So if we can get an implant in there, we will always get an implant. And then we follow some of Tarnell's research about grafting the gap and that sort of thing. But if we take a tooth out and an implant does not go in, we will graft it.
Okay, and now immediately placing the implant is also different than immediately loading. Would you immediately place and load, or just place?
We do not. No, we do not. We only place. We'll place, and we'll place a healing cap, or we'll place an anatomical healing cap, and just let it just sit there for a little while until it's integrated. So the only time I will place a temporary on a immediately placed implant is in the anterior area, and I always tell people that's just a smiling tooth. I don't want you putting anything on that tooth but a big old smile. Again, this Dentistry Uncensored, I always try to find where they argue. And I've
especially on Dental Town. I mean, it seems like all the people who do all the posting are, they're either one way or the other. But it seems like the reality of these dental graduates, when they come out of school, everybody they know that's placed 10,000 implants or more, they don't use surgical guides. And then everybody talks about surgical guides, and they're always taught by someone who's placed maybe 1,000 implants. Or I mean, most of these older periodontists are in California and Arizona will tell you, dude, they didn't even have a CBCT. They used panos, and so this is exactly what they say to the young kid. They say, if either become a surgeon and place a damn implant, or if you need training wheels, throw the bike away. They call guided implant surgery training wheels. Now, granted, they're 60, 70 years old, but what would you say to a 60, 70-year-old man who says, I never used training wheels for 30 years and she wants to make a surgical guide? What do you say to that?
Well, I'm glad you asked me that question. I've lived in both those worlds. So back when I started placing dental implants, I placed them with a pano and I placed them without a guide because that was just what we did back then. We just didn't use a whole lot of guided. And then my PhD engineering husband came into my office and he said, well, what if you're off a millimeter? And I said, okay, so we're off a millimeter. Yeah, but what if you're off a millimeter? So then, we started doing some research and just looking into it. And here's what I would say. I don't care how great you are. I don't care what kind of hands you have. I don't care what great surgeon you are. When you hit that cortical plate, you will get kicked off every single time, because you're not that good. With a guide, what will happen is that it gets really tight as the implant goes in, but it's not going to get kicked off that cortical plate. And that's the whole reason we use a guide. It's not because we don't have hands. It's not because we don't know where the implant goes. It's just that you cannot fight hard bone. So if I want to put a implant in the correct position and I want to make sure it's in the correct position, I'm going to use a guide. And how often is that? That's every time, because I want every time for that implant to go exactly where I want it. Because I've already planned the case. I've already planned the tooth. I already know where I want things. I know how I want their smile to look. And I can't afford for that to be off any. It's funny you should ask, Howard. We were just in a study group, and my husband actually said to a periodontist, how often do you see an anterior tooth where the implant restoration is up a little bit higher than the CEJ that you plan? And he said, all the time. That happens all the time. And so we said, well, you know why that happens, right? And he said, yeah, the burr kicked off the cortical plate and it just came a little bit too facial, more than I wanted, but that's okay. And that's not okay. I don't care if the patient has a low smile line. That's not okay because the patient doesn't want that. And I've had patients who have come in with those restorations and they hold up their lip and they say, can you fix this? Nobody knows it's there but me and the patient, but they don't like it. It's not okay. So why would we not use a guide? What hinders us from using a guide? Costs? Well, it's minimal cost now. Time? Well, no, we can get it in our office the same day if we want. So there's no barrier to entry for guided anymore. There used to be, but there's just not anymore. So if you're not doing it, honestly, in my opinion, it's pure laziness because you owe it to your patient to have a perfect placement.
I want to ask you something, if you agree or disagree with this statement. Some of the oldest periodontists I know say that whenever you talk about peri-implantitis, which is all over the literature, I mean, a lot of people are saying that at 5 to 9 years, 30 to 40% of implants have some form of peri-implantitis. That's a lot, 30 to 40% in 5 to 9 years. And a lot of the older guys say, you know what? When I placed them and I had attached gingiva all the way around, it wasn't an issue. There's a lot of older periodontists in this state of Arizona telling young dentists that peri-implantitis was from poor implant placement, didn't get enough attached gingiva around there. Just that blanket statement. Do you agree with that? Is it or disagree? Is it an oversimplification? What do you think about peri-implantitis since it's such a major issue in implant dentistry?
I think my answer is yes and no. So obviously there are other things that can cause peri-implantitis. Some of it depends on the patient, their home care and that sort of thing. But yes, I do believe that placement has a lot to do with it. We place a lot of implants a little bit off kilter so that the restoration has a cantilever. And you know what happens with cantilevers as you beat that up over time and the restoration's being beat up and beat up and beat up? I mean, over time, you're going to lose bone. Over time, there are going to be issues. And what happens is years down the road, the patient comes in and they start to have issues with these implants. And all of a sudden, the dentist doesn't think it's their fault because they've had it for 7 to 10 years. And they're like, wow, Mrs. Jones, what have you been doing different? This implant's got problems and you've had it for 10 years just fine. So we know that if an implant that's not placed appropriately will have problems. Most likely will have problems down the road. If it has problems, it will be way down the road. So yeah, I do agree with that.
Well, you just opened up a whole nother can of worms, so I'm gonna have to follow up with it. You were talking about occlusion, and one of the most specific questions asked on Dentaltown and email me your questions, howard@dentaltown.com, is they say, there's perio, there's caries, there's occlusion. I want to learn more about occlusion, but it looks like I have to pick a fork in the road right out of the gate. There's either neuromuscular or CR, pinky, what have you. That specific question, if she wants to learn more occlusion, you are a fellow at the Las Vegas Institute for Advanced Dental Studies, and Bill Dickerson's a big neuromuscular occlusion guy. You mentioned early in the show we went to Panky, Dawson, that's a CR deal. Should she go neuromuscular or CR?
Well, I think you have to decide that for yourself. If you're going to ask me what I believe, I love neuromuscular, and that's what I practice in my practice, because for me, allowing the muscles to dictate, allowing the patient to dictate without me having to do any manipulation, it works great for me. But I will tell you, just a couple of weeks ago, I was at Spear out in your part of the woods. You really need to look at it from every angle and every aspect to see how you can help your patients with what needs to be helped, and then make an educated decision for yourself, what works for you and for your patients. And I have to tell you, I feel like that we all start at different places, but in the end, we end in the right place, because most of the time we'll put patients in temps or we'll put patients in an orthotic, and then we'll adjust it until the patient's at a good place. And that's where we'll restore. And that happens the same in one way or another in the end. So I'm not sure that one's greater than the other. But if you ask me what I'm doing in my practice, I practice neuromuscular dentistry because that's what I know. That's what I understand. And honestly, that's what gets my patients out of pain. So I choose that.
Well, if you say neuromuscular, what would you call the other? Would you just call it CR, or what would you?
I would just call it CR.
Yeah, and my answer to the question, I think we both agree, is you have your MAGD, I have my MAGD. I would say that you just take them all. I mean, I went to LVI, went to Panky, Coyce,
Right.
Spear, all of those guys, and my gosh, and in fact, I want to talk about that. You have your master's in the AGD, your mastership in the Academy of General Dentistry. In my observation, in the last 32 years, no matter what you did in dentistry, it seemed like the people that took 100 hours of CE a year for 30 years, they always were successful. And by success, I mean they were happy, their patients were happy, they paid off their bills, their student loans, they had a nice lifestyle. And how important was getting your MAGD in your career?
Oh my God, so important. So for any student getting out of dental school, if you feel you don't have the money to invest in your education, I would tell you, pick a few good meetings and go to the meetings and just start learning. Go to AGD, go to Hinman, go to Chicago Midwinter, and just take as many courses as you can take to just learn. But you have to be educated. You have to grow, because if you think what you got in dental school makes you a dentist, you are so wrong. There's so much more out there, and you just need to get a little bit deeper into dentistry. And the only way to do that is to learn. It's so important.
Yeah, and the other part of that, I look back at when I went to these institutes, part of it is what I learned, but the other half was the dentist I met, who's now been my buddy for 30 years. And I mean, it's all about, you're a summary of the 5 people you spend the most time in. And a lot of these guys, they come out of school and they're hanging with their 5 dentist friends from dental school, and some of them hate dentistry. They're working at some mill, they're in some clinic, and they're hearing all this negativity. And then I would go to a course maybe on implants, but some guy's telling me all about some other discipline or sleep or TMJ I think the main thing is just surrounding yourself with people who just love to eat, live, breathe, and die, sleep dentistry.
So important. So I'm a member of 2 mastermind groups and 1 study club group. And, we handpick who joins these groups. And it's got to be somebody who can just take us up to the next level and who enjoys dentistry the way we enjoy dentistry. And that's so important. So pick a mentor, pick some people that you enjoy being around, and schedule some meetings and just go away and have fun with them and talk about dentistry. So important.
So do you have to take E1 before E2, before E3, should you take them in order?
Well, we advise that, but you do have to take E2 to take E3 and E4, because 3 and 4 are hands-on with patients. And if you don't take 2, you don't understand why you're doing what you're doing. So we do require 2 to take 3 and 4, but 1 is optional.
And how long are each one of these? Are they all 2-day?
They're all 2 days with the exception of the E3, which is live hands-on with patients. That is a 3-day event. And
what would you say is the dental kindergarten ideal placement? I mean, would you pick a first molar? Would it be a maxillary second bicuspid? What type of patient are you looking for? Like when you talked about that anterior tooth, the only thing I can tell you is don't touch the anterior unless it's a short, fat, bald guy with a liver spot. If they got a liver spot on their bald head, you can place number 8 or 9. Yeah. You don't even have to take a shade guide. But
especially laterals. Stay away from the laterals until you really feel comfortable. But the premolar, especially a lower premolar, even an upper premolar, it's fine. It's a real easy area. Then a lower molar would be great because you have lots of bone back there, a lot of play space to design, your guide. So that would be fine, but a premolar area is ideal.
And if she's going to come to E3 and place an implant, does she need to bring a patient, her mom or sister to place an implant? Do you provide the patients? How does that work?
Both. So we give them the opportunity to bring a patient if they want, and some doctors do want to bring their own patients, but we have patients available for them. So either way works for us.
Well, don't do what I did. My first sinus lift was on my mother-in-law. I don't know. I don't know if I was just dumb or had nerves of steel. Thank God it worked. Yeah, you might not bring your mother-in-law for your first implant.
My implant was on my father, so I feel your pain.
You did what? You did what?
My first implant was on my father, so I feel your pain. But it was kind of funny because I was using this implant wrench on my father, and I'm thinking, wow, my father taught me how to use a wrench. How cool is this?
So did you? When you grew up, were you more tomboy or girly?
Oh no, I was outside all the time. I was tinkering on cars and climbing trees, so I was very tomboy.
Very tomboy. And then your 4 children, were they all boys too?
No, 3 boys and a girl. Yeah, 3 boys and a girl.
Well, I
can't seem to get anybody to go into dentistry just yet.
Yeah, I know it's. But you know what? I was the biggest disappointment. My dad had 9 Sonic drive-ins, and he begged me to get. When I told him I was going to go to college for 8 years to be a dentist, he said it was the dumbest thing he ever heard of in his life. He said, "Hell, by the time you get out of school, you already have 3-4 restaurants to be a millionaire." And I would go to work with my dad, and he made hamburgers and onion rings. Then I'd go to work with my next door neighbor, Kenny Anderson, who's still a dentist after 50 years. And he was taking x-rays and doing root canals. And I told Dad, I said, I just don't want to make French fries for 50 years. I want to be this dentist. So that's what I told my boys. I said, you don't ever have to be a dentist, because my dad, in fact, he thought it was a personal competitive thing. So he fixed me up with Dan Carney, the founder of Pizza Hut, to get a Pizza Hut franchise. And I said, no. Then he drove me to Dallas and talked to the McDonald's people. And he said, well, get a McDonald's franchise. And it's like, Dad, I want to be a dentist. And that's why my favorite character is Hermie. When he tells when he tells Santa Claus, I think I want to be a dentist. And it was the same reaction my dad gave me. Like, are you out of your mind? So then what is E4? Is it's Prost? It's restoring the implant that you placed?
It's restoring the implant, but it's also where we go in great detail about occlusion. Not necessarily neuromuscular nor CR, but we talk about occlusion on the implant, how it should be loaded, and that sort of thing. So yeah, they get to deliver the pros on their patient and look at the occlusion. Then we talk about everything that goes into pros delivery, removable and fixed.
You know, when everybody talks about implants, you know, it's kind of bizarre. Like, you go to all the big meetings, and it's always some guy talking about all-on-4. And when you look at clear choice, which the clear choice is to get an all-on-4 instead of having a full denture, you know, they're only doing about 18,000 arches a year, and our country has 325 million people. So their 18,000 arches a year isn't even in the plus or minus exactness of the American population. But I see that, you know, I'm out here, maybe it's because I'm in Arizona, a lot of retirees, but 10% of Americans at age 64 are totally dentureless, and at 74, it's 20%. And it seems like, you know, you're talking about all these all-on-4s, but, you know, just one implant in the middle, two implant, an overdenture could satisfy 100 Americans for every all-on-4. What do you think about the overdenture?
And change their life. Yeah, no, we do overdentures all the time. It's really amazing the difference it can make for a patient. Now, listen, given the choice, a patient will always want fixed, and we understand that. But there are cases where patients just cannot do a fix for one reason or another, usually financial, and that's okay. If we can just at least give them two to hold their lower down, it changes their world. I mean, it gives them so much more confidence. They're able to go out and eat and smile and just feel comfortable about who they are. And a lot of patients don't even realize that's an option still. How can you not know in today's society that that's even an option? We still see patients who come in with their dentures loose and they want to know what they can do. And we say, well, let's place a couple implants. And they say, oh, am I a candidate? Can I do that? Do I have enough bone? Yes, yes, and yes. And it's really simple, and it's not too expensive.
And it's so bizarre because not only do they just love it to death, but they always tell me first, well, my upper denture is fine. It's just lower denture. So then you place two implants and an overdenture on the bottom, and now that's so awesome. Now their upper denture isn't any good anymore because everything is relative. The upper denture is only perfect because the lower denture is so horrible. And I wish our profession would talk more about overdentures than all-on-4, because I'm pretty darn sure there's more poor people than rich people, unless I'm reading a different newspaper than everyone else. I want to go to the, when you're talking about prosthodontics, I want to go to when you restore, taking an impression. Are you a digital scanner? Are you a vinyl polysiloxane? How are you taking impressions?
Yes and yes. So we scan, but we do take PVS impressions also if we need to or should we need to. So we teach both. We have 3 different scanners available for the Institute, and we allow them to do whatever they do in their office. If they want to experiment with scanning, they've never done it, we allow them to do that. If they're comfortable doing the analog version, we allow them to do that. We want them to have whatever it needs for them to be successful in their office and take them to that next level. So that's what we allow.
Well,
and we find most of the time doctors want to do the scanning, whether they're digital or not, because they really want to feel it and experiment with it and just see how simple it is.
Well, it's tough because if you're going to go into Invisalign, Invisalign's owned by Align Technology, which owns iTero. So then they want to do the iTero. If you just are doing crown and bridge, a lot of people say the 3Shape is out of Denmark is the best. 3M has a true depth scanner. What 3 scanners did you get? And if she was only going to buy one, what would you recommend?
So we have the CEREC. And the CEREC is a viable option for implants, for crowns, and for Invisalign. So that's a great option. And I truly believe CEREC's a great asset in your office to do single crowns or to do inlays and onlays. So if you're going to start with something, that's a great place to start. We also have Trios 3Shape, but they don't play well with Invisalign. So you have to be careful with that. If you're going to use them for Invisalign, they don't play. And then there's iTero, which you can use for Invisalign, and you can use it for your crown and bridge and your implants. Trios has worked really well for us. We use their 3Shape planning. We also use Implant planning, and we use Galileo's planning. We use everything, and we teach it all. We want to teach every system because we don't want you to be limited to one thing or another. That's why we kind of have an open forum as far as implants, scanners, planning software. We want you to look at everything and decide what works best for you.
Well, I noticed you said you did not mention 3M's True Def. Is that because you have to use a powder to scan, or why did you not mention 3M?
Yes. Well, I honestly, it's not something that we use on a daily basis here. And yeah, it's a little bit more cumbersome to use that powder. So it's not something that I find a lot of people want to know a lot about. Usually it's 3-shape Itero or Cerac that they're interested in. And so those are the 3 that we focus on.
So are you a Cerac owner? I mean, do you like Cerac CAD/CAM technology?
Oh my God, we've been Cerac owners since the Cerac 3 came out. Do you remember when that was, Howard? That was way back in the day.
Unfortunately, I bought the Cerac 1, I think in 87 or 88, and then I was so excited to get the Cerac 2. So I remember when it was still a project funded by the government of France. Did you know it was the French government's the one who did all the heavy lifting, and then after 10 years they gave up on it, and then it came to America, and someone took and you know what the problem was? You know what the problem was with Cerac 1, 2, and 3? It was Intel. They had to write limited code. Remember the Y2K? These millennials don't remember the Y2K, but in order to save space, they just put 2 numbers for the year, and then when it turned 2000, the computers all thought it was going to be 1900 again. And so they basically could not do what they did today until Intel's microprocessors, got out. They were basically Moore's law. Every 2 years, they were doubling the number of chips on the transistors on the wafer. But now it's 2019. So at 2019 is a Dentsply Sirona Cerac CAD/CAM a buy?
Oh, yes, I think most definitely. When I bought my Cerac 3, and I wanted the 2. I wanted the 2 really bad. My engineering husband said, just hold on, it's going to be better, it's going to be greater. So I held out. And when I bought my 3, I literally kept track of how many patients I did crowns on and what it would have cost me had it gone to the lab, minus what it cost me for my blocks. And I just kept a track. And within 6 months, I had paid for the machine. I mean, it paid for itself. Not only that, but it was a marketing tool. Patients were in awe, especially back then. Oh my God, I can get my crown in one day. And it cuts down on the amount of chair time. So I'm saving there. So I don't see how you could go wrong with any type of in-office meal system. But Cerac's been around for so long. It's just so easy. And now they have their new Prime Scan. The Prime Scan's out. So that's even faster, better, do it more.
Who has the Prime Scan? Dentsply Sirona?
Cerac. Yeah.
The Prime Scan.
Correct. So,
You also are with the International Association for Orthodontics out of Milwaukee, Wisconsin. So I assume, are you doing more clear aligners or are you doing more fixed braces?
I do both. If I have the opportunity to use clear aligners, I like that because I can keep the teeth clean and, healthy gums and that sort of thing. But there are times when I need to use wires and I just feel like wires work better in my hand. So I'll use wires. And then come on, kids, they want wires. They want the cool colors. They want to be part of their crowd. So they want braces. I'll have to tell you, since you brought this up, orthodontics is a great place to get started if you're a new dentist, because it's one of those areas where everybody wants it. And when a mom comes in the office and I say, okay, it's time for your child to have orthodontics, they say, okay, how much? When do we get started? Let's go. Because they understand that value already. It's been created from years and years and years of the procedure being out there. So it's a great place for a young doctor to get started if they enjoy orthodontics. And in dental school, they make it so complicated, and it's really not complicated at all. It's rather simple once you understand the process and you understand how teeth work and wires work and torque and that sort of thing.
Well, we'll talk about let's switch gears to ortho for a minute before we go back. But you have your fellow with the International Association of Orthodontics. Talk about that. Why did you do that?
First of all, I love accreditation in any organization. I always strive, if I'm a member of an organization, to be accredited in the organization, because it only makes me a better dentist. Because what they require of you to gain fellowship and mastership and Diplomate pushes you to be a better dentist and to strive harder and to take it to another level. So I always push for that. And I would encourage anybody to push for that. And that's why I did it with the Orthodontic Association, because I I felt like I needed to dig a little bit harder and understand things a little bit better. And when you have to present a case to an examiner and have an examiner look at your work, let me tell you, you work a little bit harder to make sure your case is finished really the right way. And so, that's the kind of thing that you have to do when you get accredited. And I would encourage anybody, if they're a member of an organization, take it to the next level. Don't just be a member, become an accredited member, become a better dentist.
Yeah, I agree. The CE is everything. They just kind of keep learning. But, another thing, the young kids, when we got out of school, cosmetic dentistry was so much worse because the dentists weren't using ortho. And so in order to do veneer cases, they often had to do root canals on the peg laterals and all this filing down teeth. And now, so back when I got out of school, all the cosmetic dentists didn't use any ortho. And that was a lot, it was not very minimally invasive, and it was not conservative at all. And now what I love about cosmetic dentistry is you can unravel all that stuff with ortho and clear aligners. And also, I want you to check this, because where I call baloney is when a dentist treats his spouse and kids differently than his patients. Like the dad would say, oh, no, you're not getting veneers. You're going to have braces and bleaching. But then he couldn't do braces, so then he'd go to the office, and all those cases were filed down to crowns and veneers, whatever. So would you agree or disagree with the statement that you cannot consider yourself a cosmetic dentist if you can't do orthodontics?
100% agree. 100%. Minimal invasive dentistry is what we do in today's society. We do not want to do any more in the mouth than we have to do in the mouth. And so if we can align the teeth and put them in the correct position, it changes everything. And I'll tell you, Howard, it's changed the way I treat TMJ. I mean, I for my TMD patients, we used to do full mouth restorations on those patients to get them to a solid area, and not anymore. Now we put them in braces, we move some things around, we support the joint, the muscles, and life's a lot happier and a lot less invasive and a lot less expensive for those patients. And patients don't mind.
And who's the director, or who's the head cheese at the International Association of Orthodontics?
You know what? They just had a director change, so I can't answer that question for you.
Okay, but do you recommend that group?
Oh, 100%. Absolutely. So they're a group of general dentists who place braces, who do clear aligners, and their education is beyond all else. I mean, it's just incredible, the support that you get from that group. It's great.
Is it Jacob Plonner, DDS? You don't know?
I can't tell you that.
Okay, and then I got to ask you for one other one, just because I don't want to leave it out. My good buddy Bill Dickerson, you got your fellow at the Las Vegas Institute for Advanced Studies. He's came on this show. What do you think of LVI? Would that?
So I'll tell you, LVI really changed the way I practice dentistry. So I had taken a ton of CE prior to going to LVI, and I actually didn't want to go to LVI. You know, over time, people poo-poo one direction or another, especially with occlusion. And so I had made up my mind that I didn't need to be educated by LVI because I had been told that, I wasn't going to gain a whole lot more. And my husband actually challenged me. He said, Bobbi, when do you not go and see for yourself? And I thought, you know what, you're right. I need to go take a class and at least see for myself, because people will say, no, you don't, those people are crazy. You don't need to do what they're doing, but you really need to go and explore for yourself. And when I went into the first class at LVI, I thought, gosh, this concept of how to treat my patient and how to take it to the next level was really what I had been looking for. And it changed the way I practice dentistry. It helped me become a better cosmetic dentist. It helped me be able to treat my patients with TMD, and we do a tremendous amount of TMD in our office. It's the first implant course I took was at LVI. The first ortho course I took was at LVI, because there's so much support there, and they're still taking it to another level. They just introduced myofunctional therapy. We're huge myofunctional therapy people in our office. I mean, it just all goes together: airway, breathing, functioning. So, LVI has a lot of that training, and they have good support, and the fellowship is great. So I would encourage anybody to go.
And then I have to ask you about your last one, which was a, what did they call that? Master's AGD, Diplomate in International College, a fellow with the International Consortium, fellow Las Vegas Institute. It was the other one. It was the Facial Beauty Institute.
Facial Beauty Institute. So Facial Beauty Institute was started by a dentist named Dr. Steve Galella out of Memphis, Tennessee. Brilliant, brilliant mastermind guy. Just amazing. But his philosophy is, let's put the teeth to support the face. So, oftentimes a child will go to the orthodontist and they'll say, oh yeah, let's straighten your teeth. I'm more interested in supporting your profile. I don't want to extract teeth and lose that upper lip support on a female, because God knows as we get older, we lose that anyway. So Facial Beauty Institute helps to take you through a controlled arch orthodontic system to support the face and facial growth. So I love that institute. It really changed the way I practice dentistry as far as orthodontics, and it helped me to look at people and their facial structures to see what they needed before I looked at their teeth, which I think is so important.
Yeah, and again, when I was little, at the end of World War II, they were averaging over 5.5 kids per family, so only the worst case of the child got ortho, and none of the other family members did. I mean, basically, you sent the only kid who could never get married with those teeth, and you fixed that one up. And if you're just mildly crowded, you weren't even a candidate. But it seemed like back when I was a kid, so many of the cases, almost a half, were 4 bicuspid extraction cases. And now in 2019, it's about 25%. What do you think of that? What do you think of the 25% 4 bicuspid extraction? And do you agree that it used to be 50%?
Well, yes, I do. I would say it probably used to be even higher than 50%. But I'll tell you, I see a lot of cases that I can finish very quickly if I take teeth out, or I can take my time and I can develop the arch and I can give them a beautiful smile with a beautiful profile. And I'd rather take my time and develop the arch. So I think oftentimes we jump to taking teeth out a lot quicker just to get the patient through ortho, thinking that's what the patient wants. And certainly that's what the dentist wants. And that's not necessarily what's best for the patient in the long run. So anytime I can finish ortho or get a patient through ortho without extracting teeth, I will. And I can tell you, less than 10 cases, probably even less than 5, have I ever extracted teeth. Ironically enough, twice on family members. But, it's just rare when I feel like I have to extract teeth, because we can develop the arch, especially if we get them early enough. So, yeah, I think it's becoming less and less, and I think that's a good thing. And, we also have to think about airway, because when we extract teeth and pull things back and we start encroaching on tongue space, and now the tongue's down in the floor of the mouth, and now we have smaller airway, we're developing sleep apnea patients, and we have to be really careful. But we're just learning so much more about this airway thing. I mean, there's so much more coming to the horizon that is changing the way we practice it as dentists.
Well, I can't believe we went over an hour, but I still got to ask you. Can I ask you one overtime subject question?
Absolutely.
You're on faculty at University of Carolina Dental School. Your dean, Scott S. DeRossi, is one of the only deans I know that has an MBA. We've talked about so much about clinical dentistry, and we went over an hour, and we never mentioned an MBA, a business of dentistry. How important? Right. How would you compare the importance of your clinical skills to business skills? And what do you think of the fact that a dean has a DMD and an MBA?
I think that's, first of all, he's one of the most brilliant people I've ever met. I love him. I love his personality. But I think that's so important. And I think that we don't put nearly enough emphasis on the business side of dentistry. Whether you're an associate or you're a business owner, you're still in the business of dentistry. And
do you agree that dentistry is a team sport and you got to get everyone on the team involved and educated?
100%. And it's funny, it takes us a little while to recognize that, because I was the same way you were. I woke up one day and I had this aha moment where I was like, wait a minute, I need to develop my team too, not just myself. So you're so busy working on your own clinical skills that you forget that you have all these other people that need to develop with you. So if you take them along the way, man, it changes the world. It really does. It just changes life.
2 more really short questions. How does Robert Stanley and Bobbi Stanley, was your name really Bobby and his was really Robert? And does he have to go by Robert because he can't go by Bob if you're Bobby?
Yeah. So when I met him, he had been going by Bob and literally had just started going by Robert. I guess God said, you're going to meet this Bobby, so you need to change your name. So yeah, when I met him, he was Robert, and thank goodness he wasn't Bob anymore. So it's worked. But weird enough, we named our first son Robbie. You know, he's Robert III. We named him Robbie. That really complicates things. But people think it's a joke sometimes when we introduce ourselves.
Okay, so last question. I hate to ask this because I'm a man, you're a woman, but a lot of women seriously struggle with the issue that they're you know, I got two dental schools in my backyard. One's in Mesa, AT Still. The other one's in Glendale, Midwestern, and they seriously have emotional pain and suffering, wondering their biology tells them and the world tells them, and I tell them the most important thing I ever did was I made 4 children. I mean, Eric, Greg, Ryan, and Zach. Everything I did professionally isn't even a footnote to that. But they want to be a super mom. And the truth of the matter is that if you're a woman dentist and your husband is a plumber, guess who still is going to have to do the majority of the cooking and the cleaning and the homework and all that kind of stuff. So we do live behind the times in equality. And she's coming out of school. Her exact question is, I want to be the best mother, but I also want to be a dentist. So would I be better off just getting a job at Aspen and so I don't have to do the business dentistry, and then after 5 o'clock I can go be the best mom, or should I open up my own practice? So if your kids came first, would you rather be working at Aspen or owning your own place?
I would do it exactly the way I did it. I opened my own practice. So as I was planning my practice, I had my first child. When my doors opened, I had an infant with a baby in my belly. I mean, literally, I did not stop life because I knew I wanted to be a dentist and I knew I wanted to be a mom. And I just said, I'm going to be the best at both of them. And you can. There are people who tell you you can't, but you can. I've closed my office early to coach cross country at my kids' school. I couldn't do that if I was an Aspen employee. And it works. I arrange my hours around my kids' school hours because I own my own practice. I can open when I want and I can close when I want. I can't do that as an employee. My kids always came first, family first. I tell my employees that for their families, family comes first. But I love what I do, and I'm always going to be the best at what I do, and I'm always going to give dentistry 100%, but not at the expense of my children. I don't think as an employee, I can give my kids as much as I can as a business owner. I just don't feel like I could.
So I want to ask you if this is a fair critique or not. Some people, you know, when I was in dental school, you know, the senior class had 1 woman. Mine had, you know, a dozen. Now they're half women. A lot of people are making macroeconomic bets that one of the reasons DSOs will continue to thrive is because the women aren't going to want to own their own business. They want to be an employee. But I look back at my class of '87. All the women, not only did they open up their own practice, they, on average, their offices were at least 50% bigger than the men. I mean, just so many of those women just crushed. I mean, Stephanie Carmada, Lisa Gonzalez, just super unbelievable dentists. But do you think the graduating class going from all male to half women, will that feed DSOs, or do you not buy that?
I don't buy that at all. I don't think that has anything to do with it. I think there are always going to be dentists, male or female, who don't want to own their own practice, who want to be an employee, and great. They can go to a DSO and it works great for them. But I don't think it has anything to do with gender at all. I don't. The female dentists that I see coming out of dental school now, they're on fire. They want to own their own practice. They want to be their own person. And I love that. I think that's part of the reason they went to dental school, because they really want to stand on their own 2 feet and be their own person, which means being a business owner. So I don't think it has anything to do with gender at all. No.
And here's the last word, the last fact. I mean, come on, guys. I've been doing this 32 years. When I meet a dental student who's been an associate 5 years out of school, they've had 5 different jobs. They
Yes.
keep running. It's like, if this was a successful strategy and you're going to graduate in 2019 next month, then just go 4 years back, get all the names of the graduates that graduated in 2015, call them up, and they should all say, oh, yes, I've been an associate at this clinic for 4 years and I love it. And then when you find out that nobody said that, you can
Yes.
quit chasing your unicorn. I mean, the bottom line is dentists, physicians, and lawyers, they make horrible employees. They're too smart. They want to do everything their own way. And I can assure you that the happiest you're ever going to be is when you don't answer to anyone but yourself. And the type of person that became a doctor isn't the type of person to become an employee. So I'll just want to throw my homies under a bridge that you guys make the worst employees that I've ever seen. And I feel sorry for anybody that has to have 100 of you working for them, because nobody can make you happy. My last question is, I hope someday you grace Dentaltown with an online CE course or more. It would really add to the prestige of Dentaltown to have courses by you. I'm your biggest fan. It was just an honor to podcast interview you today. Thank you so much for coming on the show today.
Thank you, Howard. I really appreciate it. I enjoyed it. Thank you.
All right. Have a great day.